First of all, good morning, good afternoon, and good evening to all participants for the first episode. My name is Taksapon Thamarangsi, but please call me Meg in short by my nickname. It is my pleasure and my honor to serve you as a moderator for today's session in very important topic. Welcome you all to the Healthier Population webinar series. This will run every Thursday from June to July at lunchtime. And it is open to all walk of life, be it expert, be it professional, be it the practitioner, policymaker. So we all welcome you to discuss for the first phase 8 topics of the host. Can you go to next slide, please, before we go back to this? For the 8th topic, yep. If you see on your screen, please block your calendar every Thursday lunchtime in South Asia. It is very okay. Please bring your healthy meal to have it in front of your computer or your laptop or your tablet there. So starting from today, but from next week, we will discuss about tobacco, then waste management, and then e-health, healthy city, rehabilitation, palliative, worker health, nutrition, and healthy diet. So that will be the list for welcome for you all to join every Thursday lunchtime in South Asia and early afternoon in the Southeast Asia part. Next slide, please. Okay, so this is a ground rule. I would like to recommend for all participants here. So first of all, we respect each other. We allow only registered participants to join. Hope that our registration process is friendly enough. You have to fill in a few boxes. And secondly, during the webinar, please mute your microphone if you accidentally unmute your microphone. For time management, we will have 25 minutes sharp for presentation. Today we have 4 panelists and then 25 minutes for Q&A. So everyone will be a speaker. So we do the parallel. If you have any comment or any questions you want to chat, you put on your chat box there and address everyone, all participants, so we can have interaction among panelists and among participants. Because of the time limit for 25 minutes, I will read it out with your name. For some questions, we will go 3 or 4 questions in one round, go to panelists, and we will select if you have a very common and very important point question to make. We will try our best to make you that you can read it out for 1 minute. And lastly, the material, our PowerPoint presentation, subject for the conference from speaker, all technical tools, particularly the visual technical tool, advocacy material will be available through this website. If you want to have it, please go there. If you have any further problem, please contact the organizer. Yep. Now we go for the next slide, the first slide, please. For today, no, about the panelists first. Okay, for today's session, we have a very important about suicide prevention in the context of COVID-19. Co-host, please go back to the first slide. Yep, please, this one. If you expand a little bit. Okay, thank you, that's great. So if you want to have a few figures to think about, firstly, 800,000. The WHO estimate that every year, so this is before we have COVID-19, every year we have 800,000 loss of life due to suicide. And it is the leading cause of death among young people, be it male or female. It is within top 3 ranking If that 800,000 is too many, now I would like to introduce you another number, 40. 40 seconds. Every 40 seconds, we lost one life from suicide. So that is very common. And with every death from suicide, estimately, there are 20 more. Each single death, there's 20 more attempting. For one successful suicide, there's 20 attempting, and 100 more at risk. So we are not talking about the problem of a few, but this is a problem of the mass. And if you look at our WHO estimate mortality in 2016, and when we adjust for age for the population, Southeast Asia region, WHO Southeast Asia regions come number one. We are the hotspot in terms of suicide at 13.4 death per 100,000 population. That is almost 30% higher than the global average. So my last point for introduction is about suicide mortality is also an SDG indicator, an indicator for SDG. That is indicator 3.4.2. So we have high level commitment. The issue for us is about how to. And it's our great honor to have 4 experts in the region to show. In front of your screen, we have 4 experts there. First, Dr. Lakshmi Vijayakumar from India. You give us a theoretical view of suicide prevention. Then Dr. Natakon Champatong and Dr. Thalini Rajapakse will show us how Thailand and Sri Lanka prevent suicide. So that is a good practice in the region. The fourth speaker, Dr. Chen Chodorji, will remind us about what to do, what should we avoid, and what should we concern when addressing suicide in the region. And after that, I will open the floor to all. And Dr. Nazneen Anwar, our regional advisor on mental health and substance abuse, will show you some product that we have before we go into the conclusion. With that, no further, can I invite Dr. Lakshmi Vijayakumar to give us 5 minutes for presentation in terms of pandemic and suicide. The floor is yours.
Thank you very much for the introduction, and thank you for inviting me for this. We know that any pandemic causes a lot of mental health issues. It increases depression, anxiety, PTSD in the population. And this pandemic has really made the entire world anxious and worried, and the uncertainty of future has been a huge problem. But what about the association of suicide during the pandemics? We have 2 incidents when during the influenza epidemic, there were more suicides in the US, and during the SARS epidemic, older people in Hong Kong had more suicides. But this COVID, in the early phase of the pandemic, we have preliminary results from New Zealand, Japan, United Kingdom, and even in some of the states in the US, where the suicides are a little less than what it was expected, which is in consonant with the theory that when there is a pandemic, when there is a distress like a war or anything or a disaster, there is more cohesiveness and people join together and the sense of isolation is reduced and the suicides come down. But invariably, the following economic fallout, when there is a recession and when there is an economic fallout, the suicides increase dramatically. And this pandemic is peculiar in the sense that what is advised is social distancing, or rather physical distancing. And we know that one of the protective factors for suicide is being connected socially. And that is reduced because of the current situation. Can I have the next slide, please? Yes, India went into I think one of the countries which went into a lockdown. Almost 1.3 billion people locked down for in the initial lockdown. And we tracked, this is a preliminary results, it is not yet published. We tracked all the suicides based on the newspaper from all over the country, all the 60 English language newspapers. And I am just highlighting some of the differences which we find. Traditionally in India, it is the young female who are at a higher risk for suicide. But now we find during the lockdown, men between 30 and 40 years have higher suicide. And surprisingly, most of the suicides seem to be employed. So which means that they may be worried about the economic issues or job losses and reduced economic potential. And those could be the reasons. And not very surprisingly, we found that the method of jumping in front of trains has come down a lot, because no trains were there, only some goods carriers were happening. And also surprisingly, we found that using of pesticides has also come down, because majority of the farming activities were temporarily stopped. Can I have the next slide, please? So what are the risk factors we found based on these? We almost found about 320 suicides during the lockdown, the individual suicides, which is about 50% more than a similar period in 2019. But we cannot really say that that is a 60% increase, because it could be a reporting bias, because we got the information from the newspaper, because when a suicide happens during COVID, invariably there is a higher chance of it being reported than at other times. But if we look at the characteristics, we found that quite a sizable amount of suicides were associated with alcohol use disorders, and alcohol related suicide was quite a surprising thing. The other issue was, who are the vulnerable people? We found that domestic violence had increased significantly, at least in Tamil Nadu. In those lockdown period, we had 616 calls to the domestic violence helpline. And the real vulnerable population now we have in our country are the migrant workers, who are caught between the home state and the state in which they are domiciled. And many of them have gone back to even more difficult circumstances. So they are feeling even more depressed and suicidal. Next slide, please. So what can be done about it? What are the actions which we can take, and who are the responsible stakeholders, and what are the indicators? For now, the states have gone into a lockdown where alcohol is not very freely available. So there should be more limiting the sales of alcohol, and per person quotas can be done, and there has to be a lot of messaging about safe drinking practices, because we find that many of the calls which has been received by helpline people, people have, once the liquor shops are open, they have gone into a binge drinking, have jumped from the heights and jumped in, hang themselves and get into fights. So messages about safe drinking and controlled alcohol sales, and more stringent measures in distributing alcohol to the younger people needs to be, and this will also reduce the domestic violence. It needs to be our immediate target. Next slide, please. The other thing is, during the COVID, many organizations and countries have set up a lot of helplines for COVID, for assistance, for hospitals, and so on, and all helplines. If these helplines can be trained, and if these people who are manning the helplines can be trained to ask simply 2 questions. Have you seriously thought of suicide in the past 1 month? Have you ever attempted suicide? That will flag up all the staff, the NGOs, all the people who are working, and to be able to identify people who are at a higher risk, provide referral pathways, and provide psychosocial support to this. So simply asking of all the helplines, which could be an economic helpline or a farmer's helpline or for the migrant or for domestic or for childline, if all the helplines could be encouraged to ask these two questions, we would be able to prevent many suicides. Next slide, please. The other thing is the media. Naturally, the media has been sensationally reporting about suicide. And even though last September, the Press Council of India has given a clear direction that suicide, how to report on suicide, most of the media people do not follow the guidelines given by the Press Council of India. And this should be encouraged to do that, because we know that repeated media reporting of suicides can increase suicides, particularly in the vulnerable population. And in fact, the International Association for Suicide Prevention has come with a resource on how to report suicide during COVID or COVID-related suicides. So I think if all the information broadcasting ministries in the countries can follow these principles, we can reduce sensational reporting of suicides and reduce suicides among the vulnerable population. Next slide, please. So this is just a flow chart. I know I have been given 5 minutes and I think I'm almost reaching that 5 minutes. I don't want to overstep into another speaker's time, but this is a time when we have to collaborate. This is a time for multi-sectoral collaboration, because it is just not the health sector alone which would have a role here. We have to have a role along with the Ministry of Agriculture, Environment, Chemicals, Fertilizers, Information and Broadcasting, Education Ministry. And this is a time when we all have to collaborate, cooperate, and then it will be possible for us to prevent suicides. Thank you.
Thank you very much, Dr. Lakshmi. That is great. We have seen the association, interesting association between suicide and disaster outbreak or any incidents, and not focus only on the time of the incident itself, but also the consequence. We have seen this in the Nepal earthquake, in 2004 tsunami. So that happened. And secondly, we have changing pattern of suicide profile. We're changing in terms of who are vulnerable more in this particular time, and changing in terms of exposed to risk factor, who, what, and how. Very helpful recommendation on screening through helpline, which is second by the Monira Rahman. And then about working through media. Mr. Hassan Mohammed asked about how to get the file. That's all in the link. And if you cannot get it, please ask the organizer. Next speaker, go to Dr. Natakon Champatong from Thailand. He will discuss about what is a Thailand model to address this one, this suicide prevention. Now 5 minutes is yours, Dr. Natakon.
Thank you very much, Dr. Taksapon. Good afternoon, ladies and gentlemen. I'm Dr. Natakon, the Director of National Suicide Prevention Center of Thailand. And I today would like to present to you the suicide prevention strategies during the dark times of COVID-19. Next slide, please. This slide, you can see that the suicide rate in Thailand was always around 6 to 6.5 per 100,000 population. And this range of suicide rate has been persist for 10 to 20 years ago. But there is only one period of time that the rate was over the 7 or over the 7.5. It was after Tom Yam Goong economic crisis, which is one of the greatest economic crisis affected to Thailand. And if you're focusing on the year 1997 to 1999, this slide also tells us about the influence of the economic crisis is always not immediately. At that time, it took at least 12 months to 24 months for obviously effect that everyone can see to suicide rate. And this slide also tells us that if economic crisis was happened, we just have not more than 6 to 12 months to prepare everything to face and to support the worst case scenario from the suicide attempt or suicide committed. Next slide, please. But in Thailand, the National Suicide Prevention Center has collected the suicide surveillance reporting system from the committed case, almost every suicide committed case, in conjunction with the death certificates issued by the government, so we can access to the cause leading to committed suicide in almost all of the cases. And if you're focusing on the January to April 2020, the first 4 months of 2020, we found that the economic crisis, the red one, the economic factors play more significant role from compared with the last year. And I can say that this is quite striking compared with the last year. It was 39.8% sharing. It is percent sharing because there is no one reason for someone becomes suicidal. So every case is multifactorial. But the alcohol factor played the less significant role from January to April. And it might be the effect according to the legislation related to the sales of the liquors or the alcohol beverage. All purchases of liquors and alcohol beverage can be done in April, and any violation can get you in trouble like the other country. So in April 2020, we have found the decreased number of suicide deaths by alcohol. Perhaps maybe it confirmed the fact that the alcohol consumption has strong relation to the suicide, and the health intervention concerning to the alcohol is so much less effective comparing with the legislation or comparing with the law. Next slide, please. This slide, let's focusing on the AR or the attributable risk of suicide. You can see that in 2019, alcohol played a very significant role leading to suicide, and AR is agonized to the suicide case. But in January to April, or the first 4 months of 2020, the alcohol switched the side to antagonize the suicide death, like the graph in the right side. But the economic factor and the sick factor, or the chronic illness, including mental illness and physical illness, play more important role leading to suicide in April 2020. And this information revealed that the social distancing policy could affect to the suicide rate, especially the early phase of the policy. And this could go to the next slide, please. Skip this slide, go to the next slide, please. This slide, it is about the data sourced from the 506 suicide surveillance reporting system. It's include the data from more than 1,400 deaths from suicide and nearly 3,000 attempted suicide. They reveals that there is not less than 50% sharing caused by suicide derived from the relation problems. And the chronic illness, including physical disorder and mental disorder, is the second important role, which is more than 20% sharing, as equal as the economic factor play more 20% sharing. And the reattempt is around 10 to 11 sharing, but the alcohol is less than 10% sharing. Next slide, please. So the prevention keys to reduce suicide could be divided to the universal intervention and the selective intervention for the risk and the critical risk group. Next slide, please. In terms of the Ministry of the Public Health and the Department of Mental Health, today we will be focusing on the selective intervention on the risk group and the critical risk group. I would like to show you the risk approach. If we focusing on screening suicidal risk among the chronic illness, which is more than 20% sharing, like I told you, our prediction is if this policy screening the chronic illness all over the country was only 20% success, our forecasting is we can reduce the death by suicide around more than 200 deaths, or the rate of the 0.4 per 100,000 population. And for the critical risk group, which is the people with history of a suicide attempt, which we have the database of this group, because the majority of them have been diagnosed of self-injurious behavior, or ICD-10 code X60 to X84 in the medical record of the hospital. So we have
one more
all
minute,
of the,
Dr. Natakon.
Okay, thank you very much. So what we have to do is follow up and close monitoring them and prevent them from the reattempt. So next slide, please. So more than 5,000 committed suicide records in Thailand reveals that the previous attempt of the committed case, next slide please, will happen within the past 1 year. And our prediction is if we could prevent the reattempt to 80% of every attempt case, we can reduce the suicide rate by nearly 400 deaths per year, or the rate of 0.6 per 100,000 population. Next slide, please. So both policy success, that would be around the rate of 1 per 100,000 population, or we could reduce for more than 6,000 deaths per year. Thank you very much. This is my presentation.
Thank you very much, Dr. Natakon. So that is great and very interesting information to know. I think the good practice in Thailand for this case is clearly about the suicide surveillance reporting system. So the strength of information system can help us in terms of sharpen our intervention to the most vulnerable and most significant risk factor. Of course, this vulnerable group and risk factor may vary across society, across country, but it's clear that economic factor, alcohol, and chronic illness and repeated attempt, they are clearly a common risk factor, and that is changed over the time, including this COVID-19. To attendees, if you look at down your chat box, there's a two chat box. There's this one general chat. You can make comment there. We record that one. And there's another one, Q&A. If you have any question to specify to any speaker, please put at there and Q&A. Our next speaker, there is Dr. Thalini Rajapakse from Sri Lanka. Dr. Thalini, the floor is yours for 5 minutes.
Thank you. And thank you for this opportunity. Could we go to the next slide, please? Next slide, please. So in Sri Lanka, we have a relatively still high rate of suicide, most often by hanging or pesticide ingestion. And we also have high rates of hospital admission for deliberate self-poisoning. So question is, how has the COVID-19 pandemic affected this? Could we go to the next slide? Next slide, please. So this is obviously the pandemic is a new situation, but when we look at how suicide and self-harm can be prevented, as previous speakers said, it needs a multifactorial, multi-sectoral approach. And we can look at both targeted prevention as well as universal population prevention. Next slide, please. So if you look, next slide. So if you look at who might be more vulnerable to self-harm and suicide in this time of COVID, you might think about people who already have a history of illness, of psychiatric illness, past suicidal behaviors, those in difficult, restricted situations like domestic violence. So how do we support this group? Next slide. Next slide, please. So in Sri Lanka, what we've done over these past few months, during this period of Corona and curfew, where people were under legal lockdown, is to look at two main things. To support these groups, we looked at how can we establish clear pathways of care so that people know how and where they can get support from. We also looked at developing new ways of getting care, because obviously people couldn't come physically to the clinic. So the Sri Lanka College of Psychiatrists, for example, was quite involved in this. Now in Sri Lanka, we have mental health clinics in almost every district of the country. So we publicized how to access the clinics, how to call in. We also, psychiatry units in different parts of the country explored new ways of, say, distributing medication to families or people who needed them. So one way was by the post. Another way was we'd use through the local public health system and the local administrative officers, like we have Grama Niladhari officers from each area. They would come to the clinic on, say, a weekly basis and collect the medication of the people in that officer's area and take it and then give it to the patients in that area. We also use things like obviously phone helplines and looked at digital methods as well, less so. And I think this, if though not 100% coverage, this was quite useful during the past few months where people were really restricted to their homes. Now what we need to do now is to look at, can we develop this and consolidate these methods more? Next slide. Apart from this, of course, as the other speakers discussed, the next stress we are going to face, which will affect suicide and self-harm rates, is the economic insecurity that is predicted. And what we need to remember is the effects, the mental health effects of COVID will outlast COVID itself. It will be there long after COVID has settled. And the biggest problem might be the financial stressors. So this is where the multi-sectorial input comes in. Can we advocate for debt relief, unemployment benefits, even labor retraining, because people are losing jobs, so that, people are supported. This is a population level thing. People are supported to tide this economic crisis. Next slide, please. Next slide. Thank you. Together with that, in Sri Lanka, what we need to do particularly is to increase awareness of both psychiatric illness, high-risk behaviors, who might be at risk in the community and in healthcare professionals, because not just in psychiatrists, among psychiatrists, because we have a limited number of psychiatrists, though much more than before. So the general practitioner should be aware of how to detect, what to do, where to refer. For us, we also need to continue restricting suicide means, that is restricting access to pesticides particularly, and perhaps increasing vendor awareness of pesticide sales and even medicinal sales. Another speaker mentioned about the effect of media reporting and the need for responsible media reporting. So I just emphasize that's very important. And another thing we've noticed in Sri Lanka is there's a lot of stigma around having COVID as well, which I'd be interested to know whether it's there in other countries as well in South Asia. So when people are diagnosed to have corona, the stigma of corona seems to be a bigger stressor than the infection itself. And that's actually highlighted by the media, which can be very stressful. So responsible media reporting is very important. And to do all this, obviously, we're going to need prioritization of mental health services. Now, I say this because understandably, in times of crisis like this, money tends to be funded elsewhere, away from mental health. We need to highlight that we need mental health resources, particularly in the next few weeks and months. Next slide, please. Next. Thank you. So what we need to also do is to keep monitoring our suicide and self-harm rates and to adapt our strategies as we go along. Thank you.
Thank you very much, Dr. Thalini. That is the great experience there. And thank you for the remind us about the importance of universal prevention, but also focus on risk factor and their important role of stakeholder there. And now you have raised two important issue. One is about service and care by non-specialists in the low resource setting. That is important. And secondly, I think in terms of monitoring, and one particular issue with COVID is the COVID stigma itself. So that is the emerging risk factor during this COVID-19. And thank you for all your question and answer and comment. I think this is very interactive, and you can show what you practice in your country as well for all the participants. Can I go to the fourth the speaker, Dr. Chencho Dorji from the Land of Happiness. The floor is yours for 5 minutes. Over to you, Dr. Chencho.
Good afternoon, Dr. Thaksapon and all the participants. Thank you for giving me this opportunity. Can I go to the next slide, please? As you know, Bhutan has started a national suicide prevention program some 8 years ago. We are now in the second phase. Next slide, please. Now, as you know that suicide is a multi-sectoral approach, and so my next slide is a framework. I'm not going to go into these details, too busy, but what we are trying to say is, suicide cannot be just tackled or addressed by health services alone. We have so many other factors. The next slide. And to that extent, we have developed so many training manuals for teachers, for CSOs, NGOs, and health workers. But this is particularly a top-down approach. Next slide, please. Top-down approach. What I mean is, all these agencies working in silos. That is the biggest challenge for us to address suicide, because it is a multi-sectoral approach, but we need the commitment and the cooperation of multi-sectoral forces. Now, what this COVID has given us an opportunity is, we are now doing a bottoms-up approach by mobilizing volunteers at the community level. Volunteers like school counselors, health counselors, social workers. So we'll be forming teams at various levels, for example, at the community, at the district, at the national, which I'm leading now. And these are all volunteer forms. And the advantage of that voluntary group is we're breaking down those silos, those barriers, and they're all able to come together in one room and then provide the support that they need, because one counselor alone cannot deal with this suicide, which is such a complex issue. At the moment, we are giving a lot of psychological first aid for all the volunteers. We have trained something like 10,000 volunteers, including health workers, all the frontline workers. We are giving psychosocial support. We are doing crisis counseling. Next slide, please. Next slide, yes. Now, this is a very complex diagram, but what I'm trying to show here is we have done an overall mapping of so many SOPs. We have something like 16 SOPs. And here, there's a national 5 lines here. Anybody can count the counselor. The counselor can then divide into 4 themes: information, distress, psychological distress, substance abuse, alcohol withdrawal, violence, and self-harm, which is where the suicide is mostly about. Physical safety, counselor determines whether it's mild, severe, psychosocial support. There's a mobile team going around, especially in the capital city, Thimphu, and some other adjoining towns where there are people in quarantine. And then we have special quarantine for people who have medical, mental, substance abuse problems. And these are supported by a group of multi-sectoral forces: psychiatric, narcotics, police, national women for coming children. What is important in the SOP is when there is a crisis situation or a lockdown, how do we operate the situation? And we have people's names and numbers given here. And those focal persons will then organize at their own agency levels what needs to be done. So we have in one page all those people who require that. The next slide, please. And I'm going to show you another template, which is operational at the district or the community level. It's less complex because there are less players in the districts, but nonetheless, the medical team plays a big pivotal role here because a lot of medical issues, we're talking of violence and self-harm here again. If there's a self-harm and needs medical attention, the medical team cannot alone address all the issues. So we need multiple players like the police in terms of violence, protection officers, child support program, social workers. And this template is given to all the district teams so that they can map out the resources within their own locations. They put the name and numbers so that if any of the team members find somebody who needs referral, they can do that immediately. Next slide, please. So this template is a work in progress. We have still not completely completed it. It's still a draft stage, but what I'm showing here is we are now training all these counselors in self-harm, suicidal ideation, and suicide attempt, and how they should address this, how they should assess at various links, risk, high, low. If it's a suicide attempt, use PS suicide attempt scale, and then they decide whether it's a high risk or it's a low risk. If it's a high risk, then there's safety, security, and then referral. So all these are mapped out in a way that it's simple at that level when there's a crisis situation. Fortunately for us here in Bhutan, right now, we are still in the orange zone and we don't have community spread. We don't have a lockdown, but this is also a good opportunity for us to mobilize all these teams in the districts and communities so they are well prepared when a crisis situation might erupt. Some of the teams in the bordering districts, India, they're already operating. So we have at least 5-6 teams in the border towns who are operational. At the national level, we have 5 hotlines, and those teams in the districts are getting activated. We have dedicated helplines where people can call directly, and they are not charged for that. The next slide, please.
Yep, you have 1 more minute, please, Dr. Chencho.
All right, so I'm going to end this with this, what I call as the 5 fingers. So the essence of our training is basically create a safe environment, psychoeducation on mental health, depression, alcoholism, which are the high risk for suicide, offer active psychosocial support and counseling, safety planning, especially when they have suicide ideation or self-harm or even suicide attempts, and support for the carers, including the families who suffer a lot. And then, of course, referral support for that. With that, I end my presentation. Thank you very much.
Thank you very much, Dr. Chencho. So that is a key. 3 lessons learned from Bhutan is the first benefit of integrated approach to all levels and breaking the silo. That is very important. We cannot deal with specialists or even mental health, the department or sector. Secondly, it is a agreed guideline. So that is very easy to use if for participants, if you closely looked at the Bhutan guideline, you can see even the contact of those. If we have this problem, that is phone number to call. And the third one is, be readiness. We integrate the suicide prevention into the national response to COVID-19, and we can bring it at the when we need it. Now I open the floor for the question. I will read the first round. I will read the key question that I got for 3 or 4, and then we ask our participant to the respond. First is from Dr. Helal Ahmed, asking about how we can use social support, social structure, community, and family. That is strength, intrinsic strength in our region to help the suicide prevention. Secondly is about how we can apply about helpline and screening to helplines that is introduced by Dr. Lakshmi in more broad terms. And then in terms of we have experience from Indonesia to share, in which I will ask Ms. Indar Devi Yanti when she is ready to connect and read it out. So and there's a few who asked about the effectiveness of suicide prevention measure, in particular to address the risk factor like alcohol. Now we sure that controlling alcohol to a legalizing measure like ban of sale can help, including the pesticide control. Panelists would like to address first. Can I go to Dr. Lakshmi? How do you see if we can upscale the screening to broader extent, please?
This has been a part of the question which has been developed, called the Ask You question from the NIMH, where they have 4 questions to screen everybody who comes to the emergency department. But in our settings, it is enough if you ask 2 questions. And if the helplines can ask these questions, then you can flag up those people for more follow-up, psychosocial support, or referral to the health services, or referral to the NGOs. So the major difficulty is many of them are reluctant to ask this question. In fact, I have one question from the chat box which says, if you ask the question for a person who is already troubled, will it not cause more problem? So research has shown that asking the question has not increased the suicidal intent of anybody. On the other hand, it is considered to be the first step towards suicide prevention, because it shows the person who is suicidal that you are willing to talk about the negative emotions, which he or she is not able to talk to anybody. So there is no research which has shown that asking the question increases suicidal risk. In fact, in the WHO World Suicide Report, we have written that, please, this is a myth, please ask the suicidal question to people who are distressed and vulnerable, because that would be the first step in suicide prevention.
Thank you very much. Can I
come in?
Yeah, please, Dr. Chencho. Yep.
So here in Bhutan, we actually developed information package with QR codes. So people can just log onto the QR code and then have an online survey, anonymous. Especially in quarantines, it's so helpful for us to pick up those people who are at high risk. They do not have to give their names or their identities, but we can still pick them up through GPS, which quarantine facility somebody's in a psychological distress or self-harming or even withdrawing from a drug. So this has been quite effective in our setup. I just wanted to share that. Yeah.
Okay, thank you very much. Can I go
Could
to
I
next?
come in?
Yeah,
Yes.
please.
Yeah, Philini here. I
Yep.
just saw some queries about whether the restriction of pesticides is effective in suicide reduction. Now, it was actually in Sri Lanka in the mid-90s, we had the second highest suicide rate in the world of 45 per 100,000 suicides per year. And most of these were by ingestion of pesticides. And one stringent measure that was taken after that was to completely ban certain very lethal pesticides and to reduce the lethality of the ones that were available. And subsequently, with that restriction of pesticides, since 95, our suicide rates have come progressively down. Now it's not very low, but it's about 14 per 100,000 now, compared to say 47 per 100,000 in 1995. So restriction of means in that instance has clearly demonstrated a drop in rates of suicide. And I think similar stories have been seen in UK in the past with coal gas restrictions and so on. It is true that we still have access to pesticides, but many of the very lethal organophosphates, for example, were removed. We are still looking at trying to get some pesticides banned because there are particularly 2 that here. And for alcohol restrictions also, in Sri Lanka, over the curfew period, alcohol was restricted, not available. What happens in these countries, the drinking does become less and the suicide becomes less, but we have illicit alcohol, illegally brewed alcohol. So people switch to that.
Okay,
Thank you.
Thank you. Thank you very much. Can I go to the Miss Sama Hussain, the advisor to the WHO Director General on Mental Health and Autism? Miss Sama, can we have you live? Okay. Organizer, please help me to connect.
Hi.
Hi. Thanks. Great. Good afternoon. You.
Good afternoon. How are you?
Okay. Great. Great.
I'm sorry, I was disconnected for a bit.
Okay. Please. Let's deliver your intervention. 1 or 2 minutes. Yeah, please.
Well, you have such a fantastic panelist. Thank you so much. You really brought to attention a lot of critical issues. As one of my requests would be really having been a member, somebody who has lost close family and friends to suicide. I think to a large part, what is an ongoing issue is even when, say, families realize there are things that are going on, they really don't know how to address it. And that kind of support that as a preventative and a curative method really should be part of it. There's been a lot of talk about methods and pesticides, but I think one of the things we have to realize that along with removing this pesticide, the core issue is a person's emotional well-being and feeling helpless or feeling unable to resolve whatever crisis they're going through in life. And if we could find various methods to get this message across, especially to our young people. In Bangladesh, a lot of the situations that we have are related to eve teasing, a lot of it are related to family relationship issues, and certainly domestic violence issues. And under these pandemic kind of situations where families are locked down and feeling even more helpless, there is no other scope. So if we are truly going to address the issue of suicide, we cannot address it without creating more of a family support unit, and not just understanding this person needs help, but understanding what kind of triggers may make it difficult for them to see any other options in life. There's the thing that at the core of it is the person is made to feel that they are the problem, and that removing them is the better solution. And it isn't the case, but I think that is at the core of the perception. So unless you remove that thinking that there can be another solution, this is going to be an issue that's going to be ongoing. We'll just keep on putting bandages on, but not really resolving the core problem. But thank you so much. This is a fantastic topic, and I'm glad it's a priority. Thank you.
Thank you very much, Mr. Maso, for your very key points in terms of that suicide prevention is an integral part of many other issues, and again echo about the importance of family and the social structure. Can I go to Indonesia, Ms. Indah Deviyanti? I would like to report what happened and how Indonesia is fighting suicide prevention in Indonesia. Indar, Miss Indar, are you online?
Yes, I'm online. Can
okay,
you hear me
please.
clearly?
Yep, clearly. 1 minute is yours.
Okay, yeah. Yes. So thank you very much, Dr. Meg. I just would like to update you on what's Indonesia's progress in the mental health and psychosocial interventions, also preventions of the suicide in Indonesia. So WHO is working also with the Ministry of Health and organizations, professionals like the associations of the mental health nurse, and then psychologists associations, and social workers or associations also in Indonesia to actually develop the strategy on the mental health and psychosocial. This include the suicide preventions. So far, we Ministry of Health and the partners like the psychological associations has established and integrate the mental health hotline in the Ministry of Health emergency call or hotline in 119. There's a special extensions on mental health. So it hopes that it can outreach the community in need for the mental health and psychosocial support. In addition to that, actually from the community mental health nurse, we reverse to the MHPSS pyramid, that the psychosocial is really the base of this. So currently we got also the report that there has been 1,008 volunteers for the community mental health nurse, and we have actually outreached around 10,000 families and 24,000 individuals. So thanks to our college professor Budiana and also the Minister of Health for this. And what they're doing is actually to promote the health, not only the physical health, but also the mental health, increase the immunity, and then also give the informations on to the community about the COVID and provide the stress management interventions. I think that's all the progress from Indonesia. Dr. Mac, over to you.
Thank you very much, Ms. Indar. So they are running short of time at the moment, so I will ask our panelists to go for one round for 1 minute, and then to all, I promise that we will end at next, not beyond 10 minutes. Okay, there's a many questions talking about how we can prevent suicide on pediatrics, on health workers, how we can ensure, so this is from Kiran Kuna, how we ensure ethical components and quality of community support training that we would like to have for non-professional, including confidentiality. But for panelists, I have to admit that it's very headache for me to manage. So first time this webinar with this a lot of very interaction across here and there. So I have to do many box. Can I go to Dr. Nattakon? Dr. Nattakon, 1 minute is your to respond.
Okay. In Thailand, we have prepared the plan called the Combating the Fourth Wave of Pandemic of COVID-19. This plan is consists of the strategy focusing on the finding out the risk group and the which also include especially the socially vulnerable group, to evaluate them with the suicide risk. And we also provide the intervention called the community vaccine and the mental health vaccine for building the resilience of the community leaders, of the important person in the communities, to be the capacity about the resilience and building the resilience in the among the communities members. And we also prepare the hotline and also the chat line. I'm talking about the text line, like line application and WhatsApp application, and which can also screening the suicidal risk among the vulnerable group.
Okay, thank you very much. A key is we use the vaccination model to the mental health, and then this show that this is very much preventable. Can I go to Dr. Lakshmi? Your last word, please. You have to unmute your mic, please.
I think this is the time where the top-down issue, the top-down policies and fiscal stimulus and economic opportunity should merge with the bottom-up approach of community resilience, community psychosocial support. So this is absolutely the time when both the top-down and the bottom-up approach should merge together to form a safe space for people who are suicidal.
Okay, thank you very much. Can I go to Dr. Thalini?
Hello.
Yeah, please.
Hello. Thank you for that. I agree with what Dr. Lakshmi said, and I think that it's just a time. We need to have a multi-sectorial, multi-pronged approach to prevention of suicide and self-harm. I agree what it, as a different speaker said, one method alone is not enough. We need to have multiple methods using multiple sectors, and it's definitely not limited to the health sector alone. That's the way we should go forwards. Thank you.
Okay, thank you very much. And last word from Dr. Chencho. Dr. Chencho, please.
So I believe that COVID pandemic has given us an opportunity as well. For example, the use of digital technology, telepsychiatry, video conferencing now has become the buzzword. It's become the fashion now, and it's so cheap and it's so accessible. Even in a remote country like Bhutan, we have been able to use 100% this digital technology to train our counselors in the far-flung areas of Bhutan. And I think that's what we have an opportunity in hand that we must use. And this is another example. We are able to connect people in the region through this video conferencing. And obviously Zoom has become a buzzword
Thank you very much.
now.
And the experience about using e-health through QR code and making GPS, that is great. That is very doable in most countries at the moment, because everyone has smartphone at the moment. So digital health, multiple method, multiple process, and top up plus bottom down, top ground level, and with the tailor to context. That is that's a key. Can I go to Dr. Nazneen? Dr. Nazneen, do you want to recommend anything? Dr. Nazneen Anwar, our regional advisor on mental health and substance abuse, please.
Thank you, Dr. Mac, and good afternoon to everyone. And thanks for these excellent presentations. For recommendations, I think our experts have brought in and emphasized on the areas that we need to concentrate on. And given the pandemic, the COVID-19, it gives a situation where we have heard that maybe not now, but as the days go in, as we go forward, there will be more cases of suicide, and we need to be prepared. So from WHO, and I also want to acknowledge my counterpart in HQ, Alexander Fleshman. We have been working on this Live Life for Preventing Suicide. Here we have brought out 4 cross-cutting implementation strategies and 4 key effective evidence-based interventions. And as you can see that these coincides with many of our previous documents and strategies that we have advocated for. And but we are focusing on leadership, interventions, to have an innovative and financing vision for that. For evaluation, monitoring, it came out many a times while the experts were delivering their presentations. And how do we, what are the implementation strategies? Less means by restricting access, interaction with the media for responsible reporting. This has come out several times in the presentations, and we know how important this is. And we also have the young of our region. We have to build their skills for resilience and for our early identification and management. I thank you all. Thank you very much.
Yep. Do you want to introduce your tools quickly in 30 seconds? Can you do that?
Time? Yes, I will not indulge very much on it, but I will go very quickly. Mm-hmm. So the tools we have divided into 3 groups, ones with national strategies, and then we have the implementation resources, and then we have these surveillance tools. So I'll go to the next. This is the public health action, and then we have the prevention guide. I think everybody has seen this. This is one of our very first publications in 2014 to encourage and support countries to develop and strengthen suicide prevention strategies. Next, here we have the national strategies here. How to develop this document inspires governments and policymakers to establish their own national suicide prevention strategy. We have almost 4 or 5 countries in the region who have their standalone strategies. India, I know Lakshmi, you have just helped them to develop their own one. And preventing, see how they are rushing me.
Yep.
No, I have to do it very quickly. Just look at the face of all the documents. I know most of you are aware of this, and you also have contributed towards it, and we acknowledge it. And we have the WHO Mind Bank where all this is available. Our websites show all our documents, and we really want you to access. So now we go very quickly. Yes, go ahead. Yes. to show each. Safe access to pesticides for suicide prevention. The next, please. We have preventing suicide, a community engagement toolkit. We've been wanting to pilot this in the region. We haven't managed this yet, but we look forward to that. Next, please. This, everybody knows, the MHGAP intervention guide. I know Dr. Meg also brought up, and many of the presenters, how we need to train non-specialists. So here, among the 11 areas, suicide is a very important area to intervene. We have global health estimates and suicide, the timely registration and regular monitoring of suicide, which forms the backbone of the effective national suicide prevention strategy. Next, please. The practice manual for establishing and maintaining surveillance systems for suicide attempts and self-harm. We have proposed to countries to support them either in establishing hospital-based surveillance system or building on the already existing systems they might be having for injury surveillance. Next, please. These are all the resource series that we have for the gatekeepers of suicide. Thank you.
Thank you very much.
I just have one more slide, which is the regional strategy. You all know, and you have contributed on this. We had four strong objectives. Thank you.
Okay, thank you. Thank you very much. Now we have a lot of tools. We have a lot of guidelines how to turn into action. And I echo many participants, including very important and interesting comment from Mr. Muhammad Udin about how we can encourage the government to invest for the system for addressing suicide. So that is the key. All questions we try to do it behind the scene, sending I asked the panelists to address the question posed the one by one, and all presentation, all two are available in the link. You can see the link, including the advocacy material, the animation that we run in the beginning. So next week we will have the webinar series on tackling tobacco in COVID-19. There's no other high time to control tobacco than COVID-19. And if you are a fan of mental health, we will do it in early July, on the 2nd of July. E-health to strengthen frontline NCD and mental health service. So that's another perhaps preferred topic for you team. And with that, thank you very much for, hope you enjoy our webinar series, and see you next time. Thank you very much. Thank you all panelists and all participants. Bye.
Thank you. Thank you. Bye.
Thank you. Bye.
Thank you.
Thank you very much. Bye-bye.
So well. I know it must be very